particular, we want to get started. So this is being recorded. So I want to introduce our guest speaker. I'm just so excited that Sarah's able to join us because she's doing some amazing work, and her recent book um, is really, I think, so insightful. But Sarah Matt is a physician. She's a surgeon who turned health technology strategist, author, and speaker. She's held leadership roles at Oracle, Savado, NextGen, and multiple health tech startups, bringing over 2 decades of experience at the intersection of medicine and innovation. So it's a real honor to have Sarah join us today. And so, Sarah, thank you so much for taking time out of your busy schedule. I know it's very busy to join us.
Of course, I'm excited to be here. So, Mary, I'll take it from here. So, here's what I want to do today for everyone. I know it's what 9:36 Central Time. There's 46 of you on the line. I'm going to give you a short talk, but throughout, ask questions, put them in the chat, and then I know there's probably lots and lots of questions. I have a very unique, I'd say, perspective and a different career path than a lot of folks. So, I'm happy to do an Ask Me Everything if you want. So, today, I want to start with someone you've never met. She works 40 hours a week as a home health aide. She's paid hourly. She has no benefits, no paid time off. She has 3 kids. She takes 2 buses to work. She has Medicaid, which means on paper, she's insured. And she has a smartphone, but her data plan runs out by the 3rd week of every month. So she's on Wi Fi when she can find it. Now, in early 21, she heard from a coworker that vaccines were available. She didn't know which number to call, but she found a website that listed appointments at a clinic across town, but she didn't have a car. She called the number on the site and was on hold for 40 minutes. And eventually she had to hang up because she had to go pick up her kids. So she tried again the next day, and she was told the appointments she could see online were in a different county. She tried a third scheduling portal, and it asked for an insurance card, but the card in her wallet was from a plan she'd been switched off of a couple months earlier, and she didn't know the new number. So she gave up. Now, at the same time, I was doing the exact same search. I'm a physician, I have a medical degree, my MBA is from UT, I have way too many letters after my name, and I have 20 plus years navigating the healthcare system from the inside. So I know the billing codes, the formularies, the back channel numbers that don't appear on any website. And I had time. I had the ability to make calls as much as I need. I had a car and I had colleagues I could call directly. So I didn't just spend the better part of a day searching. I spent days searching every county health portal, every pharmacy scheduling system, every pop up clinic announcement I could find. And I followed leads that went nowhere, all numbers that rang busy. And I filled out waitlist forms that sent automated responses and nothing else. But I did find appointments 90 minutes away. So I want you to sit with the distance between those two stories. I had every advantage the system rewards. I had credentials, professional networks, literacy to navigate the bureaucracy that most people find completely opaque in healthcare. I had time, a car, flexibility. And the best I could do was 90 minutes away. She had none of those advantages. She had a smartphone running out of data and a hold queue she could not even afford to stay on. So the system did not fail us both equally. It inconvenienced me, but it failed her completely. And we designed that outcome into the system, not accidentally, not as an oversight, by every workflow diagram, every patient portal, every scheduling interface, every UX prototype built around a user who looks a lot like me and not like her at all. So as Mary said, I'm Dr. Sarah Matt, I'm a physician, and I study how care gets delivered, how systems fail, and what it actually takes to build something different. And what I need you to understand about the last decade, because it's the foundation for everything I'm going to say, is this. Between 2010 and 2023, the United States invested over $150 billion in digital health infrastructure. So that's your electronic medical records, telehealth platforms, patient engagement tools, all the AI assisted diagnostics, pop health, mobile apps, all this stuff. The explicit promise from every investor deck, every health system strategy document, every conference was that the technology was going to close the access gap. Digital tools will reach the patients who cannot get to the clinic. And it didn't happen. By virtually every aggregate measure of healthcare access, that gap between who gets care and who doesn't is the same today as it was before that big investment. And in some measures, it's even worse. But it's not because the technology failed. The technology, in most cases, actually worked. But it's because we deployed technology on top of a broken design and called it transformation. So for 50 years, American healthcare has been built around a specific patient, this guy. He's in his mid-30s. He speaks fluent English, has high-speed internet at home and a smartphone with a data plan he doesn't even think about. He lives within 15 miles of a major medical center, has actual health insurance with copays he can manage, reads at a college level, has paid time off to attend appointments during business hours, and he's comfortable navigating bureaucracy. And he trusts the healthcare system because the healthcare system has generally treated people who look like him pretty well. It's him. He's in every workflow diagram, every patient portal, every consumer-facing application, every telehealth onboarding screen, every UX mockup, in every health tech pitch deck for the last decade. He's the patient we designed for. And he represents at most, oops, oh, look at those go. And he represents at most a third of the people who actually need care. The other 2/3, we didn't design past them. We designed right past them. And then we called the gaps in access a social determinants problem, a health literacy problem, a patient engagement problem, as if the failure was of the patients. And it's not. So here's what the actual patient population looks like. 75 million Americans can't reliably interpret a medication label, follow a discharge instruction, or understand what a referral form is actually asking them to sign. And that's not a niche population. That's a design specification we're refusing to write. Almost 30% of rural Americans live more than 30 miles from the nearest hospital. And when you're having a stroke, a cardiac event, or a complication from pregnancy, 30 miles isn't just an inconvenience, it's a prognosis. 68 million people, and I looked up this citation like 5 times in 5 different places because I couldn't believe it. 68 million people in the US speak a language other than English at home. And the percentage of healthcare encounters conducted in those languages with a provider who actually speaks them fluently, not just a phone-based interpreter, fluently, is in the single digits. And the foundational assumption in virtually every digital health solution of the last decade, that patients have reliable broadband, a functioning device, and the skills to actually navigate something like a patient portal, it's wrong for approximately 1 in 3 Americans. 1 in 3. So not a corner case, not an edge population, 1 in 3. So we invested $150 billion in tools that work reliably for maybe 2 out of every 3 patients, maybe. And we called that healthcare transformation. So we're not failing to execute a good system. We're perfectly executing a bad design. So I've spent many years studying exactly where access fails, and it fails in 5 points. And in my book that Mary was mentioning, I call them the 5 pillars of access. And the reason to name them very precisely like this is that the fix for one pillar is not necessarily the fix for another. And confusing them can be one of the most expensive mistakes that we make in healthcare. So the wrong intervention, executed brilliantly, can produce nothing. And sometimes it actually produces less than nothing because it consumes the budget that should have addressed the actual problem. So let's talk about those pillars. The first pillar is physical. Can they get there? So let's think about dialysis. So this is for people with chronic kidney disease. They go 3 sessions a week, every week, indefinitely for their whole lives. And rural patients who have higher rates of end-stage renal disease, because they have less access to the early interventions that prevent it, sometimes travel 40 or 60 miles in each direction, 3 times a week, every week for years. So we haven't solved physical distance in kidney disease. However, we documented it really well. Physical access failure is solved by redesigning where care happens, and not just where the building is, where the touch point is. And that could be home, a community center, church, barbershop, pharmacy. The care delivery model has to move towards the actual patient. Now, the second pillar is financial. Can they afford it? And this usually makes sense to people. Okay, I know I have a hard time figuring out my medical bills. I'm sure you do too. But it's more of a cost iceberg. The copay is above the waterline. Everything else is submerged. So that half day of work they couldn't take at a job with no paid leave, the bus fare each way 3 times, the specialist referral they didn't know was coming, the prescription they filled in month 1 and couldn't refill in month 2 because rent was due, the follow-up appointment they missed when childcare fell through, and then they didn't reschedule it because there was a no-show fee, and they didn't even know if they were allowed to come back. Financial access failure is death by 1,000 transactions. And most of them are completely invisible to us because we're measuring encounters. We're not measuring the full cost of actually following the plan. The third pillar is cultural. Does the system actually speak to them? So the research on provider patient concordance is consistent across decades. When patients see providers who look like them or communicate like them, they disclose more. They follow through on referrals more often. They have measurably better chronic disease outcomes. And it's not because of warmth, it's because trust is operational. And our physician workforce doesn't actually reflect the patient population we serve. And this is not a diversity initiative, it's actually a clinical efficacy problem. To get better outcomes, we need this, and it should be treated as one. And I want to be precise about this because it matters to design work. Cultural access failure is historical. Now, I'm old. To me, the 70s were 30 years ago. The Tuskegee syphilis study literally ran until 1972. Medical textbooks as recent as the 2010s contained false physiological claims about races that influence clinical decision making. And even today in 2026, Black women in this country die in childbirth 3 to 4 times the rate of white women. And this persists whether you control for education, income, or insurance. That's not a patient engagement problem. That's a pattern the institution has created over time through documented policy and practice. Communities don't mistrust medicine abstractly. They distrust it historically with a reason, and they have receipts. The fourth pillar is digital. And this is where the most money is going because it's the easiest thing to do. Oh, we can buy something. All right, we can fix this by buying a new tool, right? And digital health tools are almost uniformly most accessible to patients who actually need them least. So health systems will deploy a digital engagement platform and utilization numbers will look great. But then when someone disaggregates the data, the finding's the same every time. The platform's being used by patients who are already engaged, already comfortable with the portal. The patients most at risk, they're not on the platform at all. They're being asked to download an app and it just doesn't happen. I call this the digital access paradox because the more sophisticated a tool, the narrower the population it actually reaches. Because performance is usually measured by engagement on the population that uses it, the gap is invisible on all these fancy hospital dashboards. So you can have excellent utilization metrics and at the same time be actively widening the access gap at the same time. Now, the COVID telehealth expansion is probably the largest natural experiment on this that we've ever had. Adoption exploded in 2020. But when researchers disaggregated utilization, the pattern was really stark. The highest adoption was among educated, insured, urban, English speaking, broadband connected patients. The populations with the most to gain from telehealth had the lowest adoption rates. The tech wasn't the problem. The deployment design assumed a user that the population did not match. So digital access failure is solved by asking before you build, What technology infrastructure does this specific community actually have? Not what we wish they had, what they actually have. And sometimes the answer is a smartphone app. Sometimes it's a phone call. Sometimes it's WhatsApp. Sometimes it's an actual van on Tuesday afternoons. The fifth pillar is trust. And this is the one we are most reluctant to discuss because it's the one we can't solve by buying something. Trust failure is not irrational. It's not a communication gap. It's a rational response to documented institutional behavior. Communities did not wake up one morning and decide to distrust medicine. They learned to distrust it. We taught them, and we've been here before. There's actually a specific trust problem in digital health right now that I don't think I hear talked about nearly enough. When a patient uses a digital health tool or my Aura Ring or whatever you're wearing right now, they're generating data and that has financial value. And it's used for product development, pop health analytics, and even in some commercial contexts, it's being sold to third parties. But patients frequently don't understand the full scope of how it's going to be used. They sign a consent form written by a legal team optimizing for coverage, not actual comprehension. I'm sure we all do it every time we go to a doctor's office. We literally just sign three things and we don't read it ever. And communities with documented historical reasons to distrust the institutions that claim to be helping them while extracting value from them, that data relationship is not an abstract concern. It's a familiar pattern. It's happened again and again. So we have 5 pillars: physical, financial, cultural, digital, and trust. And every single one is a design choice someone made or failed to make. Mary, do you need something? All good. Great. I am paying attention to y'all. The patients who fall through these gaps, they didn't fail. We failed to design for them. And that distinction is not semantic. It's actually the entire argument. If the problem is the patient, then the solution is going to be patient navigation, patient engagement. But if the problem's the design, the solution is a different design. And we've been solving for the wrong variable for 50 plus years. So here's the most accurate diagnosis I've heard of this problem. We built American healthcare from the inside out. We started with what was convenient for institutions, for health systems, for payers, for administrators, for clinicians, and built what was efficient for us. And then we hand it to patients with a manual and said, here, navigate it. We can barely navigate from the inside. And the result is a healthcare landscape where we have simultaneously some of the most advanced diagnostic technology in human history and some of the most avoidable chronic disease burden in the developed world. We have AI systems that can read a diagnostic image with specialist level accuracy. And we have patients who are never going to make it to the appointment where that image would be taken. It's not a technology problem. The tech will keep improving whether we fix this or not. It's a design problem. We designed for the wrong patient. And until we change that specification, there's no amount of additional tech that's going to change who gets served. So what does it actually look like to design for the right patient? Because I know I've been talking a lot about all the stuff going on, but I am generally optimistic about healthcare in the United States. And I use these 3 questions. I ask them before anything gets built, before we ship a product, before a workflow goes live, before a new policy is put in place. And I ask them again 6 months after, because designs that work in a conference room frequently fail in a waiting room. And I want to be honest about these questions. They're not particularly sophisticated. But the reason I talk about them in rooms like this is that we're systematically not asking them. And the reason we're not asking them is that the answers are sometimes inconvenient. So here's those simple questions. Can they reach it? Not is it technically available? Can this specific patient with their specific life in this specific context actually use what we built? Or do we just assume it? And operationally, you could test this. You could describe your median user, not your target user, your median user. And if the person in the middle of your actual utilization data doesn't actually resemble the person you said you were serving, you haven't solved access. You've actually solved access for a totally different population. The second question is, will they understand it? Not did compliance approve the consent form? Will this patient in this specific moment, under this level of stress and competing demands, understand what you're asking them to do well enough to actually make genuinely informed decisions? Or are they going to sign it because they want the provider to like them or because they think they have to? In the real world, you could test this by having someone from the community you're actually trying to serve read your patient facing materials aloud to you. Not a native English speaker who works in your organization, someone whose literacy level, medical vocabulary, and relationship to healthcare actually reflects the population you're serving. And where they pause, where they reread, where they say, I guess so, instead of, yes, I understand, that's where your solution is broken. And the third one, and again, probably the most important, is will they trust it? So, what's your community advisory structure? Does it have actual authority to change the solution? Not a board that meets twice a year to review decisions that have already been made, a structure where people inside those communities can say, this conflicts with how people in our neighborhood have experienced institutions that said they were helping us. And then it gets treated as an actual design requirement, not just a PR sensitivity. So if your community advisory structure has no actual line to the people making decisions, it's not an advisory structure. It's a glorified draft in the annual report. So can they reach it? Will they understand it? Will they trust it? If the answer to any of those is no, you haven't built healthcare access. You've built healthcare access for some people. And we've been doing that for way too long. So let me show you what it looks like when systems are actually built this way, the right way. So, two examples that I want you to remember. So, Hennepin Health in Minneapolis serves patients most health systems really don't want to even see people with serious mental illness, active substance abuse, unstable housing, recent criminal justice involvement. But their ambulatory ICU runs panels of 100 to 150 patients. Now, to remind you, the national primary care average is 2,300 patients a panel. So each team includes a physician, a social worker, a psychologist, and even an addiction counselor, because behavioral health is not a referral in their system. It's the other half of the clinical encounter. And they've also built cross system data sharing between healthcare, criminal justice, and housing services. This has dropped their ED visits, and their admissions to inpatient has also dropped. But it's also increased outpatient visits, which was the whole point. At ChenMed, which is a physician-owned primary care network operating Medicare Advantage, their patients are elderly and medically complex. They're more in the low to moderate income level. Their physicians carry 350 to 400 patients, and they see each of them on average 13 times a year. That's roughly 200 minutes of contact annually. And to give you some context, standard primary care, average across the US, is closer to 15 minutes total a year. They actually include transportation as a standard service because for an elderly patient with 5 chronic conditions and no car, transportation is no longer a social problem. It's a clinical one. So in their model, hospitalizations run 50% lower than comparable populations, and the total cost of care is almost 30% lower. Their model is full risk capitation. So this means that for them, preventing hospitalizations is actually financially rational. And when those financial incentives align with the clinical mission, you can see outcomes just like this. Now, neither one of these is a perfect template, but both kind of prove the same thing. This is a design problem. The systems that reach the patients we never designed for are not built around more compassionate physicians. They're built around different structural choices, smaller panels, integrated behavioral health, financial incentives that reward keeping people well, and transportation that belongs in the care plan. The patient we never designed for doesn't need a better app. She needs a system that was actually built with her in mind. So this is zero distance care, the elimination of every barrier between the patient and the care they need. And it goes back to those pillars: financial, physical, cultural, digital, and trust. Zero. And sometimes it doesn't conveniently fit into a budget cycle, but it works. So let me come back to early 21. Let me come back to the woman who couldn't stay on hold. We made it. My family got vaccinated after 90 minutes of driving. We had family here in upstate New York, where I am. We had flexibility that meant we could actually go where we need to go. And we had cars and time and cell phones. And I want to be honest about that because we're talking about healthcare access here. But that same year, in neighborhoods across the country, there are families who couldn't drive 90 minutes, who couldn't take the day off, who found the phone tree and ran out of data and couldn't stay on hold, who stopped not because they didn't care about their health, but because the system had been telling them consistently and clearly that it was not designed for them. And here's the thing I keep coming back to. She was right to stop. And that's not a sentence we usually say in healthcare settings, but it's an honest one. Given the information she had, given the barriers she hit, given the 3 times she had already tried and been turned away, the rational decision, based on the evidence the system had provided her, was to stop. The system had communicated as clearly as a system can that it was not built for her. We taught her to expect that. We built the system that confirmed it. And then we used the resulting gaps in care as evidence that certain populations are difficult to engage. They're not difficult to engage. They're making rational decisions based on the experience we gave them. So what if in the same city that same year, a community health worker had knocked on doors in that same neighborhood, brought materials reviewed by community members, offered scheduling that took 5 minutes, face-to-face, provided a ride? Same population, same year, different design. So every person that's listening to this right now online will make decisions about what gets built in the future through your career, whether it's a policy, a workflow, a product, hospital operations. Every protocol, every referral pathway, every budget allocation, everything you design is a choice about which patient the system will work for next year. Now, before any of those decisions get finalized, go back to these 3 questions. Can they reach it? Will they understand it? Will they trust it? And if the answer is no, go back, redesign, build it again. Because she did the math on whether to try one more time. She weighed the cost of bus fare, the hold queue, the half day of work, the 3 times she'd already been turned away. She decided the system was not worth the effort. And she was right based on every piece of evidence we gave her. So let's make it worth her while. And with that, I'll take questions. Mary, I think you're on mute. Emma, I see you raised your hand. Do you have a question?
Yeah, I do. First, I'd like to thank you for taking your time and talking with us today. We all really appreciate it, sharing your insights. Um, I wanted to know from your perspective, you were able to see the healthcare system from literally an inside perspective. And so, in terms of system change, what do you think is like the first step, to actually changing, an ideal like healthcare system in America where access is more prevalent in our society?
I think the biggest problem that we have in the healthcare system is not defining the problem. So the worst thing you can do is have someone go to a conference, see a really shiny AI tool, bring it back to their system and say, we got to use this tool, because that's looking at solutions before you actually decide what the problem is. So a lot of healthcare systems haven't really decided, well, what are we actually trying to fix? What are we aiming at? So they either haven't defined what their population really is or what their population's problems are and their needs. And once they do define it, it's a lot easier to execute and figure out, oh, well, if we can't get people to show up to the clinic, well, what can we do? Could we bring them transportation? Could we have it in a different place? But instead, they'll define it as, oh, well, we have too many no-shows. So if people kind of think about what's going on in their system and then define why that might be and what the real problem is, I think we can make real change. But it's really about problem definition.
Sarah, this is Mary. What I'm hearing, that question's an important one because it is difficult to know where to start. But I'm hearing from you, we have the ability to start at the local level and looking at
Absolutely.
our what's happening within our community that could be changed, policy
I
that could
agree.
be changed, system that could be changed. So it's got to start locally.
Yes. I think a lot of people are like, oh, well, we'll wait for the federal government to do X, Y, or Z. We can't wait anymore. So you'll notice in different states, they've put in policies that are state. And then lots of counties will make specific policies at the county level. And I live in New York State. I used to live in Texas. I lived in Austin for a decade. I practiced in Austin. I had my startup life in Austin. I went to UT for my MBA. Um, and it's interesting because the policies are slightly different. In New York State, we have extended Medicaid, for example. So, Syracuse, New York, where I live, is not a big place. It's not in Austin, but we get 1% of the nation's refugees every year here in Syracuse, New York. And since we have extended Medicaid, those refugees actually get to have coverage for oftentimes 2 years instead of 6 months or less. There's still problems, of course, but New York State has decided as a policy, they think that's important. And as a member of New York State, I have some influence on how that occurs. At the county level, people have even more control. And when you think about a specific delivery system, you have even more because delivery systems get to decide how they're going to spend their money, what their mission really is, and what they're going to focus on. Now, of course, there's constraints. There's definitely things that are going to be reimbursed or not, but every hospital system has things they can do today. And health tech companies also have the ability to decide if they're going to make their mission and their products for specific populations that need it to actually figure out where they can help. So I think everyone can start absolutely at a local level, regardless of what kind of institution you're in. So I see a couple questions in the chat here. This one is building on what I was just talking about. Could attempting change at too large a scale too quickly actually undermine its long-term success, even if the goal itself is beneficial? That's an interesting point. And I think people will think, oh, well, is this too big? Is this, is this that? It really just depends on if the organization is ready for it. So you can have a hospital system that actually has proper governance, that actually has really great culture, and they are actually organizationally ready for change. And so when they put the change in place, they can accommodate that within their existing systems. Oftentimes what I see, and whether it's federally, state, a tech company, a hospital system, you name it, they have a great idea, they have a great plan or the great technology, but their organization cannot actually change because they don't have the organizational infrastructure for change management, training, discussions, escalations for when things go wrong, trust within the organization. And so if your organization is not set up properly to absorb that change and actually spends money on that, you're not going to be able to change it no matter what the scale is. So I'd say, could we do it too big? We sure could. Could we do it too small? Absolutely. A lot just depends on the organization and their ability to have change within it. The other question I see here is, to what extent is the failure of current healthcare design driven by a lack of value-based incentives? It seems the systems struggle to work for the majority because stakeholders aren't motivated much beyond a financial perspective. Well, Arena, I'm going to tell you something that's going to hurt. Healthcare is a business. I said it. You got to follow the money. You got to follow the incentives. It's like anything. And we live in the United States. So the culture of the United States is different than the culture in some of the other places where we have more single payer systems. And if you look at single payer systems, again, more single payer systems across the world, their culture has decided that all patients deserve this much healthcare. In the United States, we, all of us, have decided that patients deserve this much healthcare. That's cultural. Of course, things are going to cost money. We have to spend our money as a nation on things, whether that's roads or planes or healthcare. And unfortunately, the entire United States has decided we think healthcare belongs here. So, yes, would I love more value based incentives? Of course. But our culture has not embraced that fully. Now, the people on this call care about all those things, but the whole United States doesn't necessarily believe that too. So, what I'd say is that oftentimes I see arguments around access as moral arguments or ethical arguments. And that's why the word health equity is becoming a very much a four-letter word, because it makes it so half of the population of the United States stops listening. Now, when you put things into economic and financial terms, everyone understands money. And when you can make the financial case to do something and it makes sense, all that other stuff goes away. I actually think it's good business to do things that improve healthcare access. And I think that we have the numbers to prove it. So when you're thinking about, hey, how can we do this? Absolutely you need the incentives to match. And sometimes you can make your arguments to show specifically how the money flows and how it's better for business to do specific things for healthcare access. Any other thoughts from the group? Oh, Maria or Mary, you're still on mute again.
Yes, when if you see me move, I'm talking to the students. That one student.
Oh, sorry.
She's going to put a question in the chat.
Of course, of course.
Just go ahead and ask the question because she can hear you.
Mm-hmm.
Mentioned like basically the way that healthcare is treated right now in the US isn't necessarily like as high a priority in terms of funding. Personally, like I think that this is something that's relatable to a lot of people my age. Is like we think that obviously we want the same change that you do, but because there's a few like very powerful entities that make a lot of money off the fact that we don't value healthcare as much, which puts more cost on like a personal consumer, and they have like powerful lobbyists and like politicians who back their policies because they're backing the politicians. Like I guess just like how do you see like systematic change happening when there's like these big barriers in the way?
So I know it can seem really disheartening because the world is absolutely on fire. It really is. I agree. And healthcare has become very politicized. So when I was writing my book, it was right after the 24 election. And it was a very, very polarized time. I mean, it still is, but everyone was really raw. And I was given the opportunity to write, and Wiley said, "We want you to write a healthcare book." And I said, "Well, what do you want me to write it on?" They said, "You tell me what's the most impactful." And I wanted to write something that would not only help change healthcare, but also bring people together. And so that's why I didn't write a health equity book. That's why I wrote a health access book, because every single person, no matter who you talk to, has a terrible story about themselves, their grandma, their kids with healthcare access. Nobody's happy with the healthcare system. Everyone's had problems getting care. And so by bringing that topic more personally in a way that everyone can actually relate to, I think it changes the topic and it makes it so that we can all talk about healthcare access. When we talk about things like the moral right of care for certain populations, people stop listening. When we talk about health equity, people stop listening. But when we think about all these big players and all this power, they do understand money. They understand economics. And everyone can understand those pieces in the United States. And so by making change that has more neutral language so people can understand it, and by using things like economic arguments, we allow people on all sides of the political spectrum to talk common language and understand each other instead of talking past each other. Yes, there's tons of barriers, but Like Mary said, I think there's lots of things we can do, not just at the federal level, but locally too. And I really think that I remain optimistic about healthcare. I'm still here pounding the drum because I know we can make big change, and we do every day. The problem is sometimes our lens is so big that we can't see the improvements for individuals. We can't see the improvements in one neighborhood or one hospital. And if we just look at the big picture, we're going to miss all those beautiful trees we've just planted. So I think there's things we can do. Now, I see another couple questions in here. Given that healthcare operates within a capitalist framework, do you think new incumbents, businesses have to drive a lot of that change from the inside to actually close access gaps? No, I don't think it has to be new businesses. And I don't actually think that the capitalist framework is bad per se. It's just a cultural element. So there's institutions that exist right now that can actually close access gaps, and it will help their existing businesses. So as an example, we have all these pharmaceutical companies. Everyone likes to, totally crap on the pharma companies because they're charging too much, whatever. Yes, they should charge less, of course. But if they increase access, that means that they actually get more people of color, more women, et cetera, into clinical trials. That actually helps them market their drugs to more kinds of people. That increases their actual total addressable market. That's good for their business. So existing entities that we want to make the bad guy can actually improve their business by including access. So again, I don't think new businesses have to drive that change from the inside. I think that existing places can too. But again, it depends on what your goals are. And so if your goal is to help access, that's one thing. If your goal is to improve your business, access might be a way to do it. The other question I see here is that given the US spends over $4 trillion annually on healthcare, but trails behind peer nations in life expectancy, isn't it time for a nationwide paradigm shift, one that actually demands the government act as a more efficient, effective regulatory body? Well, you know what, Arena? I would love that. However, half the United States doesn't necessarily think that's the case. They would like to save the money for other things that they think are more important. So while yes, I am outraged at baseline, I don't think the United States culture cares. I said it. There we go, Mary. I just ruined the whole class. I'm sorry. But I think it's true. We just have to remember, like, the people that are here in this program care about humans and healthcare and making it better, and not everyone does.
No, Sarah, I value that you're being so honest because it's true. And we can't change the culture of this country very easily at all. I mean, we're a capitalistic country, period. We can't change
Period.
that.
Yeah. But you know what? We can think of it as an demonstrable barrier, or we can think of it as a design constraint. All right, given the system I'm in, how can I design things that are going to work? Well, I won't call it equity anymore. Well, I'm going to make some economic arguments. Well, how could I do this to make it work? We can also do a ask me anything. Like, we don't even have to talk about healthcare access if you have other questions for me too.
So Sarah, I've got a question for you. In fact, I'm going to invite you to a meeting in the first Friday of May because I'm working with a small local collaborative that's trying to make some real change. And your book and you have given me so many ideas about the work that we're doing. And so thank you for that, because I think you're helping us all think differently about how we approach this. And again, we're starting at a very small level and a community level and trying to identify. And we've actually found in East Austin a community that's really doing some amazing things and very successfully. So we're trying to figure out, okay, let's learn from them. Let's understand what built the trust, what in the system is working for them, and how do we replicate that elsewhere. So I think those kinds of efforts are the kinds of things that will eventually help us improve access.
I like that. Now, Mary, when you talk to these folks, I'd suggest too, you ask them where they failed before, because behind every story of success comes a dozen times where I tried stuff and it didn't work. And it's just as important to learn from those as well.
It's great counsel. That's why I want you to come to this meeting. I'll send
Love
you
it over.
information. I'll send you information about it. Well, are there any more questions in the chat? 'Cause I can't see.
Nope,
I'm working, looking at the
nope,
screen.
nothing else in the chat.
And there aren't any other questions here in the classroom, Sarah. So thank you so much for an incredible presentation. And thank you for helping us think differently about how we go about making change, needed change. You've
Of
been fabulous.
course. Thank you. I appreciate it. And for anyone who wants to connect with me on LinkedIn, I'm very well connected in healthcare. Let me know what I can do to help you. I put out a ton of content. Please tell me I'm wrong. I would love that. Um, but the conversation needs to continue, and you folks are in a very good position to keep that conversation going.
Well said. Thank you so much. Thanks for spending your time with us today.
Of course. Have a great rest of your day, folks.
You too. Bye-bye. Abby, I am going to get off being online so I can talk to my class. And thank you so much for taking care of the technical side of this for us today.
Yes, thank you, Dr. Feria. Class, that pretty much wraps up today's session. Definitely want to encourage you guys to catch up on any required submissions. And also for those of you attending the Tableau presentations, please go ahead and hop over there. There'll be lots of great presentations on that side. Thank you, everyone. Have a great day and stay tuned for more announcements in Canvas. Thanks, y'all.
Professor, could I please ask you about my lab real quick?
Hi, Kirti. Yes, yes.
Um, so I was, I think, mentioning to you that, like, I'm not able to see the report that I created. Like, I just logged in yesterday after last week's class.
Mhm.
Um, I could share my screen and
Okay.
show you.
Yeah, go for it. Go for it.
Okay.
Okay. If you click on EHR, the EHR button, does it
Oh,
oh,
oh, um,
try my records?
oh,
Okay,
perfect.
perfect.
Oh my God. Thank you
Yeah,
so
try
much.
no problem, no problem. I get where you were at with the Windows page. But yes, under the EHR, and then you probably have to select the appropriate view. But this
Oh,
screenshot, like if you want to screenshot just where it has the lock icon,
mhm.
this page works just fine.
Oh, thank you so much. Thank you. I
Yeah.
was like, oh no, do I have to do the whole thing again? Thank you.
No, well done. That's great. Glad you were able to lock your or I guess clear all the validation issues and lock your patient up. That's great.
Thank you so much.
No problem. See, a couple of folks are still online. Were there any final questions before I close out?
I had a quick question. Hi, Prismatics, how are you?
Hi, doing good. Internet is somewhat stable today, so that's a good
That's
sign.
a win.
That's a win. Yeah, what questions did you have?
Just kind of forward looking with exam two coming up. I know you sent out that announcement. Is there, maybe I didn't see it, but is there an exam actual review, like of topics, of questions? I know it's module, the last three modules that we just covered. Um, but is there like a detailed exam review?
We don't usually provide one. I
Okay.
would definitely say focus on the learning objectives in, was it, I think it's 4, 5, 6, and 7. Again, module 5, module 6, and module 7 are pretty short. So in combination, module 4 is what we'll be focused on for the exam. Learning objectives. I think those would be the target areas to keep in mind. And also, I'll double check if y'all can access the end of module quizzes just as a helpful review. But I think thinking back to the first exam, again, those learning objectives will help you kind of create a framework of first the cheat sheet that you'll put together and what you can kind of expect with the question format, similar to what we've looked at before with exam one.
Okay, perfect. Would you suggest those module quizzes being a great place to start?
I think that'd be helpful. It wouldn't hurt to review those. If you would like to see if you can access, obviously module 5, 6, 7, the combined one isn't due till the 11th, I believe. So that obviously is accessible. But if you try and review module 4, for example, let me know if you can or cannot access that, and then I'll try and make that available for folks to review.
Let me see. Module 4. I don't. I think I can. Yes, I can see those.
Oh,
Yes.
oh, perfect. That's good. That's good news.
So
Great.
perfect.
Yeah. So feel free to review that as well. But again, I think the learning objectives are kind of the go-to, and then you can follow up with the quiz questions from the module.
Okay, perfect. So just kind of filling those in like with the slides for the learning objectives and then
Hmm.
going and seeing like actual questions for the module.
Yeah. Yeah. I think I would say that's a good game plan. You've been through the first one before, so hopefully it gives you an
Yes.
idea of what to expect. But yes, that I think that'd be a good game plan to start. I'll also keep up to date with announcements the next couple of days, just in case there's any new things that'll might be helpful with that.
Okay, perfect. And then no labs on this exam.
Yes, correct, correct. So labs are just usually separate. I think it overwhelms the because it's like a whole
The
new
scope of
interface
it.
each time, and wouldn't want to overwhelm y'all with the exam. So yeah, we keep the labs separate from the general exam questions.
Okay, perfect. Um, and then I had shown you my screenshot, and I think it looked exactly like the girl before me with the law
Yes.
patient. So then that one's good. I just filled out the reflection. Uh,
Okay.
can I email that over to you if you
Yeah,
can?
sure thing. Sure
Okay,
thing.
awesome. So I can do that. Um,
Okay.
and then quiz on Friday for this lab, and then on Saturday, I guess,
Mm-hmm.
is
Yeah, I
the
gave like a 3, 4 day window for the end of module quiz. So yeah, when you have the time to complete that, go ahead and do so. I think the 11th is the due date. That should be correct.
okay, perfect. And then I think that's it for me. And then when is that next deliverable due for the tech talk? I was trying to see um when number 2 is. Maybe I can find it. Or is that out? Maybe I'm missing it.
So sorry. Could you repeat that? I think the internet kind of lagged on my side.
Absolutely. For Tech Talk 2, that second deliverable, when is that due? I didn't see that on um
Um, let's see. I'm in the assignments page. Let me see what that one's referring to. Tech Talk 2. Is that in the modules page by chance?
I didn't actually see it. I just know that we just had deliverable 1, and so I assumed there would be a second
Oh, gotcha.
task 2.
No, no worries.
Maybe
No
that was my
worries. I
assumption.
would say, so for that part, I would say if you and your team maybe work collaboratively and you have like a draft version you'd like for me or Aria to take a look at closer to presentation date, maybe right after the exam, if you've maybe put together an outline or some kind of structure of how you want to tackle it, you can always email that over. We can review that for your team, but there wouldn't be any additional, I guess, task till we get to the presentation, until you kind of finalize the final paper as
Oh,
well. So
awesome.
yeah,
Okay.
that's pretty much it. Sorry about that
No,
confusion.
that's great. I just wasn't sure because we were trying to figure out when to meet. Um, and if there was a second task, we definitely wanted to meet kind of in that timeline. But
Yeah.
that works great.
Okay. Awesome. Yeah. I'm happy you guys are coordinating times to meet, and yeah, I think that'd be really helpful to move things along.
Okay, awesome. And then is there a day to sign up for presentations or is that just assigned?
That's usually assigned,
Perfect.
but we could always, if there's any preference, you could always let me know. And I could probably put together something for students to choose a date. I think we have 2 day options. So we could do that as well. But yeah, if there are any preferences for day one versus day two, you could always let me know ahead of time.
Okay, perfect. I don't think we do. I just was making sure that I didn't need to sign up for anything or pop on it.
Yeah. Oh yeah,
Um,
for sure. For sure.
I think that's it for me. So I'll email you over that reflection, get those two quizzes done, and start studying for exam two. I'll take
Okay.
a look at slides, fill in those learning objectives, and then go back and look at the quizzes as well. Okay. Well, thank you
Okay.
so much.
That sounds good. Thank you. Appreciate all the questions. I think that helps me make sure I'm communicating everything to the class. So that was a good thought there.
No, you've been so awesome, and it's been such a great and cohesive and easy class, not easy class, but
Oh, good.
intuitive with
Yeah.
processes
Oh,
of
I'm
how
glad to hear
everything is
that.
structured. But thank you so much. Oh, for the extra credit, uh, that's in like an hour. Is there a is it the
Yes.
same? Maybe I'm missing it. I signed up. I have the link. I'll join another.
Okay, great.
But is it
Mhm.
oh, it's a one-page paper? No.
Yeah, I believe so. I think just targeting the reflection questions. Um, so there's no specific format. As long as you, I think, answer the question, one pager is ideal.
Okay. Perfect. Awesome. And sorry, I'm trying to pull it up before. Register, yes, attend. Oh, where to start? And then is that just a email to you?
Yes, yeah, that would be just fine.
Okay, so the
Um,
same thing as the first one. Okay.
yes. I'm glad you're able to make the extra credit event.
I am too. It honestly could not be more perfect. My class is at 12:30, so it's right in that window. It could not have been more perfect.
Oh, great, great, great. Sorry, it's saying my internet's unstable, but I think I caught the gist of what you mentioned there. I'm glad that worked well with your schedule.
Well, thank you so much. Sorry to keep you over, but I really appreciate your time.
Oh, no worries, no worries at all. Thank you, Samantha. Reach out if you need anything. Okay. Nandini, just want to double check if you had any questions at this time. If not, we'll go ahead and close things out here. All right. Thanks, y'all. Thank you so much, Aria. Appreciate all you do. Y'all take care today.
Of course, you too, Abby. See you later.
Thank you. Bye.